Hello, my name is Wade Green, and this is my quality improvement project entitled Concussion Education and Reporting Intention, a Quality Improvement Initiative. We'll start off this project by examining the quality gap between knowledge and the available educational materials and symptom reporting. Much of the knowledge and educational materials that are disseminated to patients, to student athletes, on our college and university campuses really have done a good job of increasing knowledge, and that knowledge usually is still retained after a period of 1 to 2 months. However, unfortunately, that knowledge and the educational materials that are available unfortunately have not done a good job at changing behavior, as we still know that less than 50% of concussions are reported each year, meaning that the vast majority still go unreported. Having said that, the goal of this project is to develop an educational program that will hopefully address this quality gap. This project sought to address 3 different criteria in regards to STEEP, and that was safety, equality, and patient-centeredness. We would hope that this concussion education program would optimize safety by encouraging reporting. Additionally, those patients that have never had access to an athletic trainer or may not have ever received any educational instruction in regards to concussion would benefit equally from this educational intervention. And then also, patient-centeredness is achieved by taking into account not just knowledge, but the social and environmental factors that these patients engage with on a daily basis when dealing with concussion and when attempting to work through the diagnosis of a concussion in the process of recovery. The QI team in this project consisted of athletic trainers, physicians, patients or student athletes, and athletic administrators. Athletic trainers were mainly responsible for conception, design, and delivery of the educational material, as well as evaluation of its efficacy. Physicians are intended to review and approve the recommendations of the material in this project prior to it being disseminated to patients. It's the hope that patients would complete during this project surveys assessing their level of knowledge and intention to report, and that those would be measured over time to evaluate the effectiveness of the program. Athletic department personnel would be there to help us handle logistical aspects of this QI project, including logistics, timing, scheduling, and those types of things. So when we examine how this project will be different and how it will satisfy the patient-centered component, we need to look at the socio-ecological framework and the theory of planned behavior. More specifically, as we examine the socio-ecological framework, we'll notice that it's made up of varying levels of influence: the interpersonal dimension, the interpersonal dimension, the environmental dimension, and the policy dimension. We're going to focus mainly on the intrapersonal and interpersonal dimensions. Those are the dimensions that deal with, firstly, a patient's beliefs or your beliefs and decisions about concussion, and then at the interpersonal level, others' beliefs and decisions about concussion that may influence you. And then lastly, we'll touch on briefly the environment, meaning the culture and sports influence on your ability to make decisions in regards to concussion in this case. In simplifying our aim statement, we sought to increase the perceived importance of symptom reporting, as well as see an increase in behaviors that result in reporting of concussion symptoms during the preseason practice portion of the 2017 football season. We had to really narrow our aim here to attempt to really implement this project in more of a pilot testing type of fashion. Additionally, we picked one domain out of the socioeconomic framework, that is the intrapersonal domain, and we sought to apply the theory of planned behavior to that domain. So by that, addressing things like attitude, subjective norms, and perceived behavioral control, which will be touched on in further detail later. This flow chart addresses the current process that brings us to our current quality improvement um, initiative. So, like many other universities across the country, we disseminate educational materials every single year. However, those educational materials are those that are mandated by the NCAA, such as those in paper form, a video that is produced by the NCAA. And those materials are encapsulated within a lecture to our patients at the beginning of every school year. Now, the one thing that we don't do is measure perception, or value of concussion materials, education materials. As far as looking at the effects of how that may play into concussion, when a patient is identified with a possible concussion, our concussion management plan is initiated. Now, there may be other factors, such as if that concussion was self-reported, that may carry negative consequences for that individual on both an interpersonal and potentially an interpersonal level. And those are factors that we have not been addressing. This cause and effect diagram also helps us to really understand the barriers that may cause us a little bit of difficulty in this project. And those really fall into four main areas: people, policy, environmental factors, and materials. As far as people goes, those really may fall into the category of physicians who may not be adequately trained in concussion management, and who may have errant beliefs and even practices in regards to concussion evaluation and diagnosis. Parents and families as well may expect their son or their daughter to play through symptoms due to the perceived importance of athletic participation, or simply ignorance. And then obviously a lack of knowledge may contribute to unawareness or an unwillingness to report. Environmental factors could be pressure from teammates or coaches, the perceived time of year. For example, if we have a young man or a young woman that is playing in a playoff game, they may not be as willing to report symptoms that could take them out of that important game. It very well could be that we need to ask the question, are our policies actually effective? Policies that promote non-participation in active people may actually influence non-reporting itself. Educational materials that simply seek to increase knowledge, as we know, may ignore social constructs that the patient directly deals with on a daily basis. And then again, while those educational materials may increase knowledge, usually this is not sustained for more than 2 months. And as far as we know, they don't change behavior. And this leads us to our the general statement of our problem is that self-reporting of concussion-related symptoms is perceived as a non-desirable behavior in college football athletes. How do we know that the improvements that we are attempting to measure are actually improvements? There are various tools and surveys that have actually been made available to us via previous work. One of those such surveys that will have material adapted from it is the Rosenbaum Concussion Knowledge Assessment Tool. And this covers multiple domains, not only for student athletes, but for athletic trainers and coaches. And so what we're attempting to see is that hopefully we'll be able to build our own survey based off of these previously utilized and validated instruments. Now, additionally, we're also looking at the number of reported concussions, and those are things that we would hopefully be able to track via a run chart or a control chart. So getting into the PDSA model here. So what is our process of improvement? How are we actually going to pull this project off? So in order to get into that, we need to really attempt to examine what is it exactly that our educational materials will cover. So we go back to the theory of planned behavior, and once again we pull out the interpersonal dimension of the socioeconomic framework. So the theory of planned behavior has three main parts: attitude, subjective norms, and perceived behavioral control. If we apply this to concussion, that may lead us to questions such as, What are the consequences of reporting or not reporting my concussion? Subjective norms. What will others I respect or value think if I report my concussion? And then perceived behavioral control. Patients believing that they have the ability to report their concussion under certain circumstances or conditions. These are the main areas and points of emphasis that educational content and questions will be drawn from. Plan. So, educational materials will be developed as previously mentioned, but we want to make sure that those materials also use the theory of planned behavior and the socio-ecologic framework. It needs to be noted, though, however, as well, that there may be some interplay between the interpersonal domain of the framework and the intrapersonal domain. A survey will be delivered both before and after the educational intervention is given to assess changes in beliefs and attitudes. As far as doing, we would implement this project, but then we need to stop and measure to determine our level of effectiveness. We would obviously use our reported variables, such as behavior, and then the number of concussions. Independent t-test would be used to measure an increase, a truly statistically significant increase, and then control charts would be used to assess for special cause variation. We would act based on either the presence or absence of special cause variation, as well as those results that are statistically significant. In our spread plan, we would specifically be interested in moving this initiative up the socio-ecologic framework and spreading it across populations outside of football and even into those populations of differing gender and sports setting. Thank you. Thank you so much for your time.